Morning. Welcome to the 25th annual anniversary celebration of 50 Hoops Legends, Patient Education, National Cancer breakfast. I'm Legend Cassandra Harris, Program Director at MD Anderson Cancer Center in Houston, Texas, your virtual host. Today, we're broadcasting live from Lancaster Center in Dallas, Texas, and virtually for you in other parts of the country. Congratulations to Ed and Pat. You've made it 25 years as the oldest African-American founded community, patient, and medical education nonprofit in the nation. Wow. Before we get started, we want to remember to put your questions in the chat as you think of them, or both for our live and virtual speakers as well. And we'll do our best to answer them. Now, first, as our custom, our founders, Ed and Pat Sanders, as you know, are both preachers' kids. And it is our custom to begin and end with prayer. So now we'll go live to Dr. Lester Singleton in the 50 Hoops Legends chaplain for our prayer and invocation.
Lord, once again, we just wanted to say thank you. And we invite you in once again to our silver anniversary. We give you all the honor, the glory, and the praise as we invoke your presence in our celebration. We pray, Lord, that the knowledge we receive today, that we can take it and share it with our churches, with our communities, for the benefit of people. We give you our praise and we thank you for being a part of our celebration and allowing us to be here today. And we ask your continued blessing upon us and our families. In the mighty name of Jesus, we ask and pray. Amen.
Amen. Now it's time for the 50 Hoops Impact Statement. This statement will give you some history of what 50 Hoops has accomplished over the years. After a quarter century, 50 Hoops stands as the only small African-American founded nonprofit, community patient, and continuing education certified medical education organization in the nation. The 50 Hoops National Prostate Cancer Basketball Tournaments and Health Fairs targeted African-American men 50 plus, and is singularly the oldest national prostate cancer basketball competition of its kind in the United States. From 1998 to 2008, 50 Hoops toured nearly 36 cities, educating and offering PSA screening and cancer resources, creating the African Americans in Clinical Trials National Outreach Program. Also, the creation of African American Health Matters text message service, touting nearly 60,000 subscribers, and it became our interest into communication technology. From 2008 to 2018, 50 Hoops became CE accredited and presented its first medical education events at the University of South Florida, Dallas UT Southwestern Medical Center, and Duke Cancer Institute. In 2018 through 2019, 50 Hoops traveled across the country for 2 years with the Multiple Myeloma Research Foundation, educating African Americans through a program called There's a New Cancer Initiative in Town, finding nearly a dozen survivors from coast to coast to impact the reality of this cancer. In 2020, as you know, the pandemic hit. Since 50 Hoops had a decade-old text message service, this marked the beginning of our virtual patient education events. 50 Hoops is now popular for our short, to-the-point presentations, offering resources and best practices. In 2021, 50 Hoops Legends became the cornerstone of 50 Hoops 21st Century Outreach, graduating nearly 24 legends who replicate 50 Hoops events, creating many workshops for the busy patient or executive, moving 50 Hoops to another historic milestone. We are 50 Hoops Legends. We are celebrating 25 years, and we are the future of 50 Hoops. As we join together today for our celebration, let's take a look at what some of our legends are doing. Thank you.
Good morning. Good morning across the country as we celebrate our silver anniversary. I'm legend Sheila D. Patterson, an ovarian and breast cancer survivor and co-founder of the Oak Cliff Bible Fellowship Comprehensive Cancer Support Group. With my husband, Lee J. Patterson, as assistant. We have been working with teaching hospitals, cancer patients, and other organizations across Dallas, Fort Worth, and areas throughout the United States. Oak Cliff Bible Fellowship Comprehensive Cancer Support Group is proud to host this exciting event. Over the years, the 50 Hoops Cancer Breakfasts have been designed to address various cancers our African American communities face, and today is no exception. I would now like to introduce our guests for this morning, and that is Dr. Stuart Ackerman. He is a gastroenterologist specialist at Methodist City, Plano, Texas. He received his medical device from Rutgers, New Jersey Medical School and has been in practice nearly a decade. Dr. Ackerman is a strong supporter of diversity and community patient education. He is board certified in internal medicine and gastroenterology, and has been named one of the best doctors in Dallas by D Magazine. Dr. Ackerman.
Thank you, Chair. Thank you for the introduction. I appreciate it. I apologize. I do have to have notes. I can't do it all by by heart anymore. But thank you to the Sanders and to the entire 50 Hoops organization for inviting me to speak this morning. I've been asked to give a brief discussion about stomach cancers and other issues that can affect the stomach as well. So before we get going, let's start with some boring but pretty fantastic statistics about stomach cancer. So according to the American Cancer Society, there were 26,500 new stomach cancers diagnosed in the past year and 11,130 deaths. Sounds like a lot, which it is, but in the US, there's been a drop in new cases of 1% every year over the last 10 years. So each year it continues to decline. It's thought that the reason that this might be is because we refrigerate our foods, we don't have issues in regard to contamination, and an increase in the treatment of something called H. pylori. H. pylori is a very common infection of the stomach. Many of us get this infection, and it can live in our stomach for years or even decades without knowing about it. You typically get it from the dirt, from the ground. So the most common place to catch it is actually from eating fruits and vegetables. The infection's found in about 90% of patients with stomach cancer, but there are way more than the 26,000 patients who are walking around with H. pylori. So how do we know who we check and we treat for this infection if it doesn't necessarily let us know that it's there? So the easy answer is certainly people who have symptoms. Well, what symptoms should you be thinking about where if you got them, you should go get checked out? So typically the symptoms correlate with GERD, gastroesophageal reflux disease, or reflux. The most common symptom is heartburn, but it's not the only symptom. So a lot of times people say, well, I can't have GERD. I don't have any heartburn. Well, not entirely true. So some of the other symptoms can include chest discomfort, regurgitation, where the food kind of comes back up after you eat, abdominal discomfort, even sometimes bloating or diarrhea. A lot of kind of generic symptoms. But especially if any of these symptoms are associated with a little bit of weight loss, or you notice that you're not as hungry or you're getting full a little more quickly, it's a little more concerning and you should get yourself evaluated quickly. If you're over 40 and you experience any of these symptoms, make sure to tell your doctor. You're kind of your point person for these kind of things. They're going to refer you to a gastroenterologist such as myself, someone who specializes in stomach and colon disorders. And they're probably going to recommend that you get a test called an upper endoscopy, and it's also called an EGD, if you've heard of that. It's a camera test where when you're sleeping, a gastroenterologist will go through the mouth and look at your esophagus and stomach, and they can take little pieces of tissue, little biopsies to evaluate for certain issues, just like H. pylori. You can look for cancers this way, you can look for ulcers this way, and you can look to see if you've developed any kind of long-term complications or changes from reflux, and those could be addressed. H. pylori, typically treated with antibiotics and can be eradicated. Reflux, typically treated with antacids and changes to the diet to try and decrease the amount of acidic foods that you're taking in. Stomach cancers kind of depend, right? It really depends on when it gets diagnosed. But stomach cancers that are found early have an excellent outlook. Treatments are improved. 5-year outcomes continue to improve year over year. Now, before I start answering questions, I did want to throw in, I know it wasn't on the agenda, but a quick thought about colon cancer screening. A few years ago, I was actually here and I discussed kind of candidly how this is a war that we're winning. Right? When we started taking data back in 1980, we started this initiative for colon cancer screening. And it doesn't matter where you look, which organization you go to, which statistic you pull up, the curve only goes down. And that's because of all of us in this room. Many adults get screened every year. Since we started this initiative, more and more do. And every polyp that gets found is a cancer that was avoided. But something that I want to bring up today that is different than the last time I was here is that colon cancer screening now starts at 45. So the data has proven out that we're winning and we're doing a better job more and more. So we want to make sure that more and more people get screened because we can actually eradicate the cancer over time. And it used to be that we started at age 50, but we found earlier cancers and we found better results with treating and getting rid of these polyps. So the national guideline now recommends that if you're an average risk individual, someone who does not have symptoms, someone who has no family history, you should start at 45. Certainly, if you have symptoms, you can start earlier. And if you have any family history of polyps or cancer, speak to your doctor about when exactly you should start. Thank you so much for giving me a few moments of your time this morning. And thank you again to everyone at 50 Hoops. I am more than happy to try to answer as many questions as I can, if anyone has any. Great question. So the question is, how often should you have colon cancer screening? And like every great question to a doctor, the answer is it depends. If you're an average risk individual, and we're talking specifically about doing colonoscopy, then the answer is if you don't have any polyps and you've had a good clean out, it's about every 10 years. If you have polyps, it just depends on how many, what size. Yes, sir. How about Barrett's esophagus? Is that significant in your area? Yeah, that's a great question. So the question is about Barrett's esophagus and is that significant? So I alluded to that a little bit when I mentioned about complications from reflux. So Barrett's esophagus is a change in the lining of the esophagus that occurs when you've had chronic exposure to acid over time. And this is something that takes typically years to develop. What's tricky is that someone may not understand that they've been having symptoms. They might say, well, I've had heartburn for the last month, but not realizing that a lot of their other symptoms may all have been related to reflux over time. The only way to know if you have Barrett's esophagus is to do an endoscopy and get checked. And if someone does have Barrett's esophagus, that increases their risk over time of esophageal cancer. And in order to decrease that risk, we put people on appropriate diets, we put people on medication to decrease their overall acid exposure, and then we perform endoscopies now for surveillance to follow every 3 to 5 years, depending on the situation, to make sure that there's no progression of that disease process.
We have one from our virtual audience.
I'll get right back to you, sir.
What is GERD and how is it treated?
Okay, great. So the question is, what is GERD and how is it treated? So GERD is reflux, or where acid starting in the stomach refluxes or regurgitates back into the esophagus. So it's a problem that originates in the stomach. To give it a little more nuance, I'd say it's more about either over acid production or sensitivity to acid. And depending on which parts of the body are involved, your symptoms will change based on if your esophagus is affected, if your stomach is infected, and in a small percentage, if your small intestine is affected. The treatment is typically with anti-acid medicines. The most common ones are what are called PPIs, or proton pump inhibitors. Those are the ones that you see these commercials for. And years past, you might have seen them for brands like Nexium or Prilosec. And they tend to decrease the amount of acid that you produce, and they'll heal any kind of inflammation as well. You also want to pay attention to your diet. Medicine is not magic, right? You have to have a little bit of your own skin in the game as well. And we talk about lower acid diets. The most important thing, if you remember nothing about this speech, other than one point, I'd say don't eat within a couple hours of going to sleep. It's the hardest thing to do. But when you do that, you give your stomach adequate time to completely empty out. Because when you lay down, gravity can't help you anymore. So anything that's still in your stomach, when you lay down, can now go backwards, and that causes more reflux. But there's also certain foods that can cause more reflux. I'd say the most common, probably the most acidic thing that we eat is concentrated tomatoes, tomato sauce or red sauce, right? Ketchup, red sauce, salsa. Coffee is a big one too. Doesn't mean that you can't drink coffee. Doesn't mean you can't enjoy a cup. Don't enjoy 4. Like most things in life, it's about moderation really more than anything else. And probably alcohol and citrus, and alcohol in particular, beer and red wine. They tend to be more acidic. Yes, ma'am. Sure. Are they related questions? They're related. Got it. Absolutely. Yes. So can I just repeat your first question first? Okay. Do you want me to answer it first or? Okay. So the first question from the lady in the back is, can I speak to the efficacy of colonoscopy versus Cologuard and kind of what the differences are between the two? Is that really it? Awesome. So Cologuard is a poop-based assay, right? So colonoscopy is a cancer screening tool that we use where we have a camera that's put into the colon to look at the lining and take pictures, and if we need to, do some interventions. Cologuard is a test that was developed over the last few years, which also is approved for screening, although I will point out it's only approved for screening for average risk individuals. So if you have a family history, if you've ever had a polyp in the past, you're actually not supposed to get a Cologuard because you've proven that there's a risk that you might need to get a polyp taken out. But it's a stool test where you'll get a kit, you will submit a stool sample, and they'll check it for a kind of DNA or abnormal findings within that stool. If it's there, you'll then get recommended to go get a colonoscopy to find out why the heck this test just came back positive. A lot like everything, there's always sort of pluses and minuses to every test. I'd say for a colonoscopy, the positives of a colonoscopy, direct visualization, and if you find something, you can actually do something about it right then and there. Also, you don't have to do it again for quite some time. The downside to a colonoscopy, You got to prep. Prepping is not fun. It's probably the worst part of a colonoscopy. You got to do that sort of aggressive clean out. And you got to take a day off, in order to go get the procedure. For the Cologuard, the advantage is it's easy, right? You do it in your home. You literally poop in a box and send it out, and the mail person's going to take care of it for you. The disadvantages, number one, there's about a 14% false positive rate. So at the moment, about 1 in 8 patients will get a falsely positive result. In other words, it'll tell you it's positive, but actually nothing is there. So you'll end up getting colonoscopy and they'll tell you, nope, everything's good, which far from the worst thing in the world, but kind of a little bit of distress for no reason. The second disadvantage is that you have to do it more frequently. So it's only going to find something once it grows big enough that it starts shedding this DNA. So it's not going to find small polyps. So the time frame is going to be different, and you're going to repeat that every 3 years. Not that big a deal, just something to know about the test when you're considering it. What's the second question? Yes. Okay. So the question is, can I answer what risk and relationship is there between HPV, the human papillomavirus, and gastric cancer? So that's a great question. I'll admit a little bit out of left field for me, but I'm happy to try and answer this. Yes. Yes. Oh, I'm sorry. I just want to answer this one question, and then I'm coming right back to you. So as far as HPV, HPV is a virus that's been linked with cervical cancers. We have a huge rollout years ago with a vaccination that came out called Gardasil, and we initially started having our younger female patients get vaccinated in order to try to decrease the overall incidence of HPV in the community, and it worked like gangbusters, so much so to the point where nowadays it's recommended well beyond just essentially, I believe initially it was 18 to 26-year-old women, and now it's everywhere, and even starting to roll out for men, because it's very clear that a lot of times the risk factor is men who give it to their female partners. There are specific subsets of HPV that have been associated with specific kinds of gastric cancer. So when we talk about gastric cancer in general, we're talking about more of the sporadic nature of it, meaning the ones that come from possibly lifestyle and maybe a little bit of genetics. HPV specific.
And we're back with our speaker for the National Prostate Cancer Basketball Tournament's Hardwood Workshop. This is where during the quarter and half times, the entertainment is information and Q&A about prostate cancer. To introduce our special guest speaker is legend Dr. Angela Moore, Duke Cancer Institute's Director of Community Engagement. Dr. Moore?
Good morning, everyone. I'm Dr. Angela Moore from Duke Cancer Institute. I am the director of the Office of Health Equity. I spend a lot of time going out in the community, teaching the members of the community, especially those from underserved, marginalized populations, about recommended cancer screenings, as well as I have community-facing patient navigators who help individuals get into screening. So I'm glad to be with you here this morning from Durham, North Carolina. I'm going to introduce our speaker, Dr. Keith Crawford. Dr. Keith Crawford is a director of clinical trials and patient education from Prostate Health Education Network, which is the premier organization.
Hello, I'm Dr. Keith Crawford. I'm the Director of Clinical Trials and Education at Prostate Health Education Network. I'd like to talk to you today about prostate cancer early detection screening for African American men. Early detection screening saves lives, and this is important. Men diagnosed with early stage prostate cancer have a 10-year survival rate of more than 95%. Men diagnosed with later stage prostate cancer have a 10-year survival rate near 18%. FIN has a major emphasis on educating about and promoting early detection screening towards eliminating the prostate cancer racial disparity. Now, this is a quote by Mr. Farrington, and I'm going to paraphrase it. As a 22-plus year prostate cancer survivor, he knew the importance of early detection and how it played a critical role for him. He personally designed FIN-PSA to educate and inform men about the prostate cancer early detection screening process. I'd like to introduce you to Dr. PSA. And Dr. PSA is going to talk to you about the aims of our program. So, prostate cancer early detection screening aims to reduce the deaths from prostate cancer by detecting cancer that may be life-threatening at an early stage where it may be treated and managed effectively. A lot of you may wonder, what is the prostate? It's important to recognize the prostate is part of the male reproductive system. The male reproductive system is composed of the penis, the prostate, and the testicles. Now, the prostate is found below the bladder. So this is the bladder and in front of the rectum. So if this is area here is the rectum, the prostate is located here. Bladder up top and the rectum in the back. It wraps around the tube that empties the bladder. And that's why many men may suffer from complaints about problems urinating or emptying their bladder. How big is the prostate? Now, a good way to get an idea of the size of the prostate is to compare a lemon with a walnut. The walnut is about the size of the prostate. And as I mentioned before in the image, it wraps itself around the tube that empties the bladder, the urethra. Now that we have an understanding of the prostate, where it's located, a good reference point as it relates to the size, let's talk about prostate cancer. Now, prostate cancer is the leading cause of cancer in African American men and second to skin cancer in Caucasian men. The most common form of cancer in the prostate is adenocarcinoma, which is normally a slow-growing cancer. You may wonder, how is prostate cancer detected? There's two ways. It is normally detected by prostate-specific antigen, PSA, test, and the digital rectal exam. Men typically begin early detection screening for prostate cancer between ages 40 and 50, depending on your risk of being diagnosed with the disease. The PSA test and DRE are used for early detection screening. Let's go a little bit more into detail about the PSA test. As I mentioned before, prostate-specific antigen, PSA, is a protein produced by normal as well as cancerous cells of the prostate. The PSA test was approved by the FDA to monitor prostate cancer growth, but is also used for early detection. A PSA test requires that your blood be drawn and sent to a laboratory for measurements. PSA is not just elevated in men with prostate cancer. It is also found in men with benign, this is non-cancerous problems. An example of which is benign prostate hyperplasia, known as BPH, or the enlargement of the prostate. There's no evidence suggesting that BPH leads to prostate cancer. The digital rectal exam, on the other hand, doctors examine the prostate by inserting a lubricated gloved finger into the rectum, and I showed you the relationship between the rectum and the prostate, to feel for irregularities on the surface of the prostate. This examination is called digital rectal exam, DRE. So you may wonder, why should Black men be especially interested in early detection screening? First, prostate cancer is the leading cause of cancer among Black men. All African American Black men are at high risk of being diagnosed with and dying from prostate cancer. Black men are diagnosed at a rate 77% higher than white men and die at a rate 120% higher. This is the largest racial disparity for any type of major cancer for men or women. However, prostate cancer can be curable if detected early. The prostate cancer 10-year survival rate when detected early is more than 95%, compared to 18% when detected late. You may ask, at what age should Black men begin early detection screening? Black men should talk with their doctors beginning at age 40 to get a baseline PSA test. A baseline digital rectal exam should also be discussed with your doctor. PSA testing should continue to be a consideration for men with a life expectancy of 10 years or more. These recommendations are based upon information from these organizations: American Cancer Society, the National Comprehensive Cancer Network, the United States Preventive Services Task Force, and American Urological Association. So our take-home message here is talk with your doctor about baseline PSA test and DRE beginning at age 40. Now, once we have this baseline PSA test, what's next? Based upon the baseline PSA number, your doctor may perform a digital rectal exam, schedule your next PSA test, or refer you to a urologist for further tests. You should track each PSA test number and compare it to the other to see if your PSA is rising. And if so, how fast? Review with your doctor following each PSA test. Get a PSA test each year unless your doctor thinks more frequent or less frequent testing is in order. But the most important thing here is know your PSA number. What is a normal PSA? The median PSA number for men ages 40 to 49 ranges between 0.5 nanograms a mil to 0.9 nanograms a mil. Men with a PSA higher than the median are at a greater risk for prostate cancer and aggressive prostate cancer. The PSA number typically increases with age, and the rate of increase is important to track. A high PSA number does not necessarily indicate prostate cancer. Did you know exercise, sex, and an enlarged or irritated prostate may cause the PSA number to increase? So our take-home message here is track your PSA number and discuss with your doctor. You may ask, what are the potential benefits for early detection screening? A normal PSA test may put your mind at ease about your prostate cancer risk. A PSA test may find prostate cancer early before it has an opportunity to spread. However, not all prostate cancer is life-threatening, and tests are available to help determine if prostate cancer requires immediate treatment. Early detection allows for treatment of prostate cancer at an early stage that may help avoid complications from the disease. Early detection allows for treatment of prostate cancer that may reduce your risk of death from the disease. So remember, early detection may help you live longer. You may ask about what are the potential risks of early detection screening? A normal PSA test may be inaccurate and give you a false negative. An abnormal PSA test may suggest that something is wrong when it isn't. That's a false positive, and leads to other tests that may not be necessary. A high PSA test may find a prostate cancer that is slow growing and would never have caused problems. But the important thing here is this: talk with your doctor about the potential risk. Know as much as you possibly can about early detection screening. Now, you may wonder, what are some of the signs of prostate cancer? A weak or interrupted, stop and go flow of urine, a sudden urge to urinate or frequent urination, especially at night, trouble starting the flow of urine and trouble emptying the bladder completely, pain or burning while urinating, pain in the back, hips, pelvis, it doesn't go away, shortness of breath, feeling very tired, fast heartbeat, dizziness, or pale skin caused by anemia may also accompany prostate cancer. Always talk with your doctor about any of these signs. So remember, early detection saves lives. And for more information about early detection screening, please go to finpsa.com.
Dr. Mike.
Okay. Dr. Crawford, we really appreciate your time today. The slide presentation was awesome and very informative.
You're welcome.
Are you ready for us?
I'm glad to be here this morning, and congratulations too on the silver anniversary.
Thank you. I think Pat and Ed are cutting the cake so that we can be a part of the celebration.
All right.
Thank you.
You're welcome.
Okay.
Hello, hello, hello.
We hear you.
I am a 28-year prostate cancer survivor. And were it not for my surgeon, Dr. Klaus Roburn, head of urology at UT Southwestern, he suggested that Pat and I begin something to address prostate cancer in African-American men. We would not be standing here today had it not been for him. And of course, Pat. I wouldn't be here myself had it not been for her. It has been God working through thousands of people in communities across the country who have supported our work. And we want to thank them and thank God for his guidance and direction to bring us to this day, and especially thank the Arkansas Big Dogs who made our basketball tournaments come to life over the years. For this, we say thank you.
And for today, we want to thank the Lancaster Rec Center, our caterers, Dana of Sweet Creations, Jazz and Andy Johnson, who prepared the delicious Caribbean breakfast, luncheons, and dinners over the years. And again, our baker, Miss Dana Carroll, and the beautiful silver anniversary cake that was the conception of Dr. Robin Kelly. Raise your hand. That's who created this. Okay. And especially our 50 Hoops board and those joining us, Dr. Robin Kelly, Dr. Timothy Upshaw, Dr. Lester Singleton, and our host of the Oak Cliff Bible Fellowship Comprehensive Cancer Support Group, Mr. and Mrs. Lee and Sheila Patterson. Thank you so much. Dana? Okay, we're ready to cut the cake.
Cardiovascular health and cancer treatments are inextricably linked. Cardiovascular health and cancer treatment are inextricably linked. Patients with healthier hearts are more likely to complete cancer treatment and have overall better long-term health outcomes. However, many patients are not aware of short and long-term cardiovascular risks of specific cancer treatments. Moreover, racial and ethnic disparities in cardiovascular diseases and deaths are amplified after cardiotoxic cancer therapies, particularly in African Americans. These national population level risks are high in disparate Dallas-Fort Worth area communities. The Academic Community Multidisciplinary Engagement, or ACME partnership, harnesses the clinical expertise of cardio-oncologist Vlad Zaha, the lifelong community leadership of Ms. Sheila Patterson, and the community-based participatory research skills of Dr. Carolyn Smith-Morris, that's me, into singular focus, to inform cardio-oncology research and interventions with particular partner engagement and deep knowledge of our target population. Ultimately, and through future also collaborative research proposals, we aim to improve screening for cardiovascular risk prior to cancer treatment, to improve education on cardiotoxicity of cancer treatments and risk reduction among patients, and ultimately to improve long-term cancer outcomes through education and support. We are thrilled to be here partnering today with 50 Hoops and Oak Cliff Bible Fellowship support groups for cancer, and just grateful to the community partners for allowing us to join in this important effort to reduce cardio-oncological risk and improve education in the community.
I'll turn it back over to Dr. Angela Moore.
Yeah, I know you all have questions. We're getting to come on and answer. So I want you to be able to ask any questions you have related to the video that you was able to see. If not, if you could put it in chat, we will have those questions as well. Dr. Crawford, can you turn your video on?
Good morning.
Good morning, excellent. Any questions related to the presentation that Dr. Crawford presented? Well, while questions are coming in, I do have one question. Dr. Crawford, I know that there's been a change over the last 10 years about when Black men should get screened for prostate cancer. And a lot of times it creates a lot of confusion. And so specifically when we're talking about African-American men, when should they start having their initial screening for prostate cancer?
Angela Moore, that's a very important, I don't know why I called you full name, because you're not in trouble yet, but that's an important question. And what people have to recognize is this: there was a lot of information out there, groups saying that you shouldn't screen, but the guidelines that exist today from the National Comprehensive Cancer Network and American Cancer Society suggests that Black men, African-American men, men of African ancestry, high-risk men, people of Ashkenazi Jews ancestry, and people that have genetic predisposition or genetic biomarkers should begin screening at age 40. So I'll repeat it again. African-American ancestry, Black folk, Black men need to begin screening at age 40. You need to have that discussion. Now, screening is not a digital rectal exam. It's not the physical exam. It's begin monitoring your PSA, because we're getting more and more reports of Black men being detected and diagnosed with prostate cancer in their late 30s. So the take-home message is this: begin that discussion with your doctor at age 40.
What's new in prevention and treatment of prostate cancer? I know it's sort of a large question there.
Well, I mean, there's a couple of things that are new. Normally, when you're in the past, people were thinking radiation or surgery are the primary means of treating cancer. Now, that's the first treatment options that most people come across. But we're moving into an era of personalized medicine, where they're understanding what your genetic makeup is. And once they know what your genetic makeup is, they have therapies, they have drugs that perform extremely well if you have genetic markers. Now, what's interesting is there's a genetic marker, BRCA, which is breast BRCA, BRCA1, BRCA2, breast cancer, BR. BR is breast and CA is cancer. everyone used to think that BRCA genes were only associated with women and breast cancer, but that's not the case. Now it's also associated with prostate cancer, and the new lines of therapies that are coming out are work very well with people with those genetic biomarkers or genetic mutations. Now there's some other areas that have come into place, and even when we start talking about screening, normally you would get look at your PSA and then you get a biopsy. But now they're suggesting that you get an MRI. Now that MRI will give you a scan of what the topography, the surface structure, the density of the tissue, and they can detect potential sites of cancer. So that gives you more evidence that you have cancerous growth. So that's just in screening. Then the next phase, it is something that I call, if you can't see it, you can't kill it. Now we're able to use these targeted diagnostic tools that hunt down cancerous cells, not just in the prostate cancer, but throughout your body. And when they do that, it's like a missile that carries a payload. Now, the first payload is a payload that it shows where it is. Then the next payload, the next targeted missile for cancer delivers it could deliver radioactive particle that goes inside the cancer and kills the cancer. And it prevents you from having to receive radiation over a large area of your body. Not only does it have, you can use these targeted missiles for radiation, but you can also use it for very toxic chemicals. Now you take these toxic chemotherapies that would normally impact the whole body, you can concentrate them and deliver those inside the cell. So what I'm telling everyone is this: don't be afraid. We have a tremendous amount of new resources that have come out. I mean, if you went back, I mean, even before when Ed was diagnosed, there was only two major treatment options, and that was surgery or radiation. Now you have hormones that suppress and shut down the cancerous growth. You even have the ability of harnessing the power of your immune system, where an antibody, and everybody's heard of this when we start talking about COVID, and you get your vaccine so you can get elevated antibodies, so these antibodies can attack the COVID virus. Now, what happens if you have the ability to hunt down the cells that are responsible for killing the virus and concentrate those cells around the surface like bees on a honeycomb? So that's what's exciting. We don't want people to be afraid. PHIN, Prostate Health Education Network, has created online tools. PHIN, we keep everything simple. PHIN PSA, if you're interested in understanding screening. PHIN PATH, if you get diagnosed, because a lot of patients will get diagnosed with prostate cancer and it's a month or 2 months before they can even go in and get treatment. So what we're saying is, don't look at Dr. Google and try to figure out what that is. We have the guidelines that the doctors, the oncologists use for treatment at your fingertips, and that's PHIN PATH. And then there's another thing that's extremely important, and this is something that 50 Hoops recognized some time ago. Black people need to participate in clinical trials, because that's so important, because you're going to get the cutting edge technology, concierge medicine, because there's going to be a lot of people watching over you during this clinical trial. And then it's either free or very low cost. So you may get a lot of it covered by your insurance. So that's important. So when you think about it, just remember, when we start talking about clinical trials, and you may hear it, is this: it's like an ice cream sundae. So you're always going to get a standard of care. So in this ice cream sundae we create, it's like 3 scoops of ice cream, chocolate syrup, nuts, and whipped cream. So that's the standard of care. And then the clinical trial, 3 scoops of ice cream, chocolate syrup, nuts, whipped cream, and then a cherry. So we want everyone to understand that participating in clinical trials I mean, at your area academic center. And even in not necessarily, the clinical trials are coming from the academic centers like Southwestern into the community, making it available to everyone. And this is important for the people of Dallas County, especially South Dallas County, that Dallas County area, because there's a higher incidence of prostate cancer. And because of COVID, what's happening is more and more men in the state of Texas, all men, are being diagnosed with advanced disease.
Absolutely.
Thank you. Thank you. Dr. Moore, are there any other questions?
Last year, a lot of Black men have been diagnosed with prostate cancer in the later stages. So one more question, what can we do at the community level to increase awareness of cancer and prostate cancer and screening?
Well, one thing I want to say about 50 Hoops, they had the vision, and you need to partner with organizations, the academic institutions, the pharmaceutical companies need to partner with organizations like 50 Hoops in your community. And we have to educate the community. We have to go back, like Ali and Sheila, working with, and they participated with me on a pharmacy-based, a pharmaceutical company-based program in Dallas to kind of educate and bring awareness to the community. So we educate groups like 50 Hoops, educate the community, and they need funding and support from the community. They educate the community about the importance of prostate cancer, but they also educate the pharmaceutical companies who don't really have an understanding of truly what's going on at the community level. So what we can do is do our very best to spread the word. You know how many people who don't understand, who don't recognize that Prostate Cancer Awareness Month is in September? How many people are aware that the leading cause of cancer for Black men is prostate cancer? How many people know that the incidence of prostate cancer is 77% higher? And we die at 2 to almost 4 times the rate of our Caucasian brothers. It's that message has to be there. And the other singular message that has to go out there is this: just get the PSA, get the blood test. Don't worry about the digital rectal exam. Just focus on getting the blood test. Get your baseline numbers, know your numbers.
Excellent. Thank you for that that response, and hopefully those who are listening will take heed to that. And I'm going to turn it back over to Cassandra, and hopefully we have some time, some question and answer later on. So Dr. Crawford, I'm going to ask you to hang on to the end of the program. Thank you.
Okay.
Thank you, Dr.
So good morning, and thank you so much for agreeing to share your story about cancer, particularly prostate cancer. We find it, as you know, the statistics are pretty dire for men, particularly African-American men. So anything we can do to help get them the information, the resources, the education in general, we want to do that. So again, you're helping us do that. Thank you so much. And I just want to ask you some questions. Your name, please. Just
Warren.
name. Okay, Warren. Thank you, Warren. And tell me a little bit about the type of cancer that you had.
I had prostate cancer.
Okay.
I was
How did you?
diagnosed in 2010. I went in for a physical exam.
Okay.
I was at, it was a yearly exam, I think it was. And while I was there, the doctor said, well, you test your prostate. But then he said that when he did the digital exam at first, and he said he couldn't feel anything. He said, but because of your age, let's go have it. He said, then about 5 years since you had one anyway. So let's send you for a PSA. That first time I ever heard of PSA. But he said you go to LabCorp or Quest, and they have a blood test. And when it came back, I had a blood test, and about 4 weeks later, he called me back and said, I need to, he's gonna recommend a urologist for me because my PSA was out of the normal range for my age group. So, and I went to talk with the urologist. He recommended, I took one of the ones that he recommended, Dr. Kirchhoff, and he had a consultation with me and asked, did I have any, I said, I don't have any symptoms. He said, well, usually with the prostate, you don't have any symptoms. You have frequent urination. And he said, I just had that. And I said, well, I guess it changed over age, but I thought because of my age.
How old were you?
62.
You're 52 at the time?
62.
Oh, 62. Okay.
62. And I thought because of the age group, a lot of things that we get older, we see things changing. But I did and he said, when you go urinate, I said, do you have trouble getting started? I said, yes, times. If I've been sitting a long time, I said yes. So those questions. Then he said, well, schedule for a biopsy. And 2 weeks later, I went in for a biopsy. And it came back that, yes, it was positive for prostate cancer. Again, my T-scores were high. And because of the T-scores, he said, it looked like mine had been growing about 2 years. So they gave me some to schedule, to have a consultation. So you had to talk to you're married, you have to talk to your marriage partner too. So it's best to tell your marriage partner to come in because it's going to tell you some of the, and he gave me some information about prostate cancer. And so one of the things that about prostate, it's a slow growing cancer. It's one of the slower growing ones. And what the urologist do, they watch it over a period of time, see if there are any changes. And now they don't have to do the digital now. They send you for a blood test. Just the PSA, they can tell how it's advancing with the blood tests, the PSA exams. But I decided that the consultation with Dr. Kirchhoff, I decided to have the prostate surgery.
Okay.
Yeah. And some of the other options, right now they have more options. Then they had the radiation.
Oh, wow.
It had radiation, which I did not want to radiation. I didn't want to disturb anything. So I said, I'll take the chance. I'll take my, because they said they have the nerve sparing surgery, can spare the nerves. Because more the thing we worried about as our manhood, we worried about as our manhood. After that, we can't have erections or anything like that. So, but now they have the nerve sparing. They could advance that much. They spare the nerves.
So just like a laser or directly, tell me more about that. I'm not sure.
Well, mine was the surgeon down at Johns Hopkins Hospital did mine, Dr. Burnett. He's very well known in the field of prostate cancers. And he asked that I wanted to do the laser. I said, no, I want to have some eyes looking at it, not in the machines. So we had another consultation. They did more blood work, and he told me what are the things he said. A lot of the things we worried about, men were, but they can't perform anymore. But now they spare the nerves in the penis. They can spare nerves now. They have the nerve sparing. One time we can talk about what happened because they were. Didn't have the advancement that they have now, how they would do that, past the ages, but now they can spare the nerves and put the nerves aside when they do and remove the prostate. And that's well, he said, still wanted that. I said, yeah, I'll go ahead and do that. And so I was diagnosed in June 20th, diagnosed in the early part of June, and I had the surgery on June 20th.
Wow.
The part of June, because they said mine had already been growing for 2 years. It already been growing for 2 years, and the T-scores, it said, Dr. Kirchhoff will recommend I did not wait, just go ahead and get it, because I was already 62 years old. Don't wait. And here I am. It's in August I'll be 75 years old, so it's been 13.
Amen.
13 years old.
Very nice. Yeah.
Yeah, but like I said, it's good to have it done, because I'm glad, because if I had not gone and had it done, if I had not gone and had my checkup, I had a regular checkup. So do regular checkup, especially for men. We don't like to go to doctors. And I had gone in for a checkup because one of the things, my sister died at the age of 44 from colon cancer.
Oh.
And we were told that there might be a gene in our family maybe colon cancer. So that advised us each year to make sure we get checkup for colon cancer. Make sure we check because it's that's part of colon cancer check for man, prostate cancer. And I started doing that, and I'm glad I did. And did follow the advice of the doctor because it was diagnosed. And like I said, I had to say, I noticed my urine that I'd slow down urine. It wasn't as frequent, but I would get started. If I sat a long time, I had to go to the restroom. It would be slow starting. My urine would be slow starting. It would be slow starting. But I didn't have the problem of getting up at night. I didn't have that problem.
Okay.
But I noticed that mine was slow getting started.
Okay. Do you have any repercussions, anything since then that you can attribute to the prostate cancer or surgery?
Yeah, well, after the surgery, I had incontinence for about a month. And so
okay.
You would dribble and you didn't realize it. And so you felt wet. So, but now they have things for that too. So it's a lot long things that there are a lot of medical advances since I had mine in 2010. There are a lot of advances.
Great.
If I had to do all these things, I would not, because I had to think about it before, even though it was slow growing. I did think about it. I had to pray about it, but I still wanted to go through with it. But now they have so much medical advance. There's so much more knowledge out there. I would not hesitate. I would not hesitate now or going about it. But because I watched, well, two men I knew very well. They decided not to have anything. I watched them waste away because they refused to have the surgery because they were concerned about the manhood. They would not be able to perform anymore as a man. So that's I don't think that's right thinking, but each man has to make that own decision in his own mind. You have to be comfortable with the decision that you made. And I had a brother-in-law who had the same surgery I had. So had his about 5 years previously. So he gave me some pointers too, and some of the things to expect. Yes, your libido would not be what it was before, but you work around that too. You work around that. Because now they have medication to help you.
Yeah.
Yeah, the ED medications out there. So there are a lot of help for men, and we don't have to suffer anymore. There's a lot of help out there for us that they help us get through, and they help have a good mate too, because they go through it with you. Your mate have to discuss all these things with your mate because they go through the same things with you. Yeah. And so it's an open discussion. Lines of communication have to be open. You got to talk about these things. That's one the other thing you definitely have to talk about.
Do you think I'm sorry. You think a men's support group or a men's group would have been helpful, or would that, or just talking to like somebody you really trust, like your wife or?
Yes. There are support groups out there. There are some men's support groups out there. I didn't use one, but they gave me a lot of reading. But they have some books out there to give you to read about it. Some of the things you should read that before you even have the surgery or whatever you plan to do. There's a book out that I think mine is around here someplace. I have to find it, but you should read that before you make any decisions, what to expect. They interviewed about 12 men in that book, and they tell you some things to expect. But like I said, I had a brother-in-law who had it 5 years. My wife's brother had it 5 years before I did, and he was very helpful to me. So if you can find somebody else, or if you can talk to a man who's been through it. Now I've had a college classmate. He had it surgery last year, 2021. One of my college roommates, 2021. He wasn't diagnosed until he was 72, 10 years after I was. And he had it, and he said you'd rather have it taken care of than worry about the cancer in the back of your mind, because you're worried about it spreading. That's the purpose of the biopsy, to see how far it spread. But in my case, mine had not spread any other organs or anything. It was lymph nodes were clear, and we localized to the prostate. So, and that's 13 years ago now. So medical knowledge has come a long way.
Yeah. So, and you're still cancer-free, right?
Still cancer-free. I just had I just had one in September. I have my next one coming this September. 3 months from now, I have so I get them yearly, and they're all down below 1. That's what they want them to be, below 1. And mine has been below 1 for 12 years already. So
that's very good. Any advice to men or anything that you want to
get it checked? Don't take you feel the symptoms. Just make sure because they don't have to do it with the digital. We're concerned about the digital exam. They can do it through the blood now. The PSA they can do it through the blood. So you go ahead and have a blood. You go ahead and tell your doctor because you have to have a prescription to get it done. You need a prescription. Tell your doctor that I want to have PSA. Say, well, you might be 50 years. I want to know, because especially African American man, you should have it done anyway. I'd say at 40, really. You say at 40, but and you go and get the blood work done. They come back to you, tell you whether it's elevated or not, because they do it by age groups, by your age ranges, and it will show that it's elevated. And then if it's elevated, then you find a urologist and go and have a biopsy done, and the biopsy will tell you how high it is and where it's located. If it's localized to the prostate, then they can be treated right there at the prostate. Now, this new thing they have with the proton, we didn't have the proton when I had the proton. It's like radiation, but it's more pinpoint, it's more focused, right on the cancer itself.
Okay.
They didn't have that. They had the radiation where they had to be going to radiation, and that's the whole area of the scrotums. That's what I was concerned about. It might damage some other organs there.
Yeah.
But the proton surgery is more of a directly focused treatment. And of course, you can have the surgery like I did. You could have laser surgery, or you can have a man. Well, I wanted eyes looking, so make sure they got the right place.
Okay.
Well, I advise the man to have it done and pray about it, and talk to your urologist and see what he says. If it's growing really, if it's there and it's growing really slow, maybe wait a couple of years. Like the doctor said, my primary said we could we can wait and watch it, but the urologist said my T-scores mine was not in a watching place, though, even though it was localized to the prostate. He said not in a watching. We say we should either take the radiation treatment or have it taken out, or have the prostate removed. So I had those two choices, and after talking to my brother-in-law, I decided to go ahead and have the surgery.
So you had your prostate removed?
Yeah, it had to be removed. Yeah, it had to be removed. And my friend who from college, he had his removed. We had his removed too, and I'd since I'm here. 13, almost soon be 13 years later, I'm still here, and I don't worry about it anymore, because the PSA exam every year, I don't think about it. It's not in the back of my mind. Says, is it growing? Well, how fast is it growing? I don't have those dots anymore. It's not there anymore. Yeah. And plus, when they did the biopsy and they did all exams, it had not spread anyplace else. So mine was just localized in that one area, and so far it's still there, that one area. So I've been blessed. I thank the Lord that He kept beside me. He gave me a good wife who she had to go through this with me. She shared it with me. And I had to tell the men that there are so many ED meds out there now that you can, whatever strength you need to help you get through, they have it available. But that's the thing in the back of men's mind, especially the younger men that think about, I won't be able to perform anymore. That's I rate that against life. So which is more important to you? Being performing, being alive. so I would choose life.
Well, I don't want to take up more of your time, but thank you so much. So anything else that you want to say, or anything?
If any man want to talk to me, you can give my information. I'll tell them. I'll talk with them.
Oh, thank you so much.
I'm discussing it because I am well pleased. I am no regrets at all. So that I had it done. So
great.
I wouldn't regret it. I should have had it taken care of, but like I said, it had been growing 2 years, but it was 5 years between the exams, and that's it. And the doctor suggested, instead of me, he suggested, so why are you here? Let me do your prostate. I didn't bring up the fact that it was I had to wait when I went to urinate, especially if I sat. If I was on a plane for 2 or 3 hours, when I got the rest of them, I had to stand there for a minute before the urine flow would come. So, so I noticed that change. If you notice that you're slowing the urine flow, it's more effort to get a urine flow after you've been sitting, especially after you've been sitting. If you could do that, might be a good sign. You need to check it. And like they always advertise, say, "Oh, you're getting up more frequent at night." So I didn't have that problem, but I had the slow urine. So there's more than more. There's another. That's another symptom that you might want to look at if you have different urine flow. And don't attribute to age like I did. I said, "Oh, I'm just getting up. I'm 62 years old now." No, it's good that it's best to have it checked. Yeah. But I'm glad to help you. If that helps
you.
in your
Oh.
your study.
Thank you. I think it does. All right.
Yeah.
Have a great day. And this ends our session and our conversation on prostate cancer, what to
Right.
do, what some of the symptoms are. And, you know, as you said, your advice is get it checked, huh?
Get it checked. Get it checked. Yes.
All right.
Get it checked.
This is Tom Dillon with the North Texas Prostate Cancer Coalition. We are an all-volunteer 501c3 nonprofit organization that was established in 2009 to provide coordinated education and support to prostate cancer patients, survivors, caregivers, and their families across North Texas. We are supported by a team of medical advisors. The coalition also promotes public awareness of the disease and encourages all men to get screened at the appropriate age. Additionally, we regularly support various men's health events across North Texas by providing literature and knowledgeable representatives to answer questions regarding prostate cancer. For more information, you may check out our website at www.ntxpcacoalition.org.
(18F-RH-PSMA 7.3) is an investigational agent not approved by the U.S. Food and Drug Administration. This video depicts the proposed mechanism of action of 18F-RH-PSMA 7.3. In recent years, radiopharmaceutical innovations have greatly improved the ability to identify, localize, and treat prostate cancer. Blue Earth Diagnostics, a pioneer in the field of molecular imaging for prostate cancer, continues to develop innovative diagnostic and therapeutic solutions. Introducing 18F-RH-PSMA 7.3, a novel radiohybrid ligand. This investigational molecule targets prostate-specific membrane antigen, or PSMA, a transmembrane protein that is overexpressed in prostate cancer cells. It is designed to bind and to be internalized by PSMA receptors on prostate cancer cells, where it can potentially be used to detect prostate cancer using positron emission tomography. 18F-RH-PSMA 7.3 was intelligently designed by leading academic researchers to optimize its potential diagnostic properties, including enhanced binding affinity to maximize imaging signal and delayed excretion to minimize bladder activity. In addition, this is the first PSMA targeting ligand to contain 2 radionuclide acceptor sites. At the first site, a hydrocarbon-enhanced silicon fluoride acceptor is labeled with radioactive fluorine-18, a positron-emitting radionuclide. At the second acceptor site, a dotego-collator moiety is labeled with non-radioactive, naturally occurring gallium. 18F-RH-PSMA 7.3 is the first example of a novel technology called radiohybrid, or RH-PSMA. Radiohybrid molecules are designed so they can be converted for either diagnostic or therapeutic purposes. And as the base molecule remains the same, they may exhibit similar characteristics, such as binding affinity, lipophilicity, and pharmacokinetics. Blue Earth Diagnostics is committed to pursuing this and other nuclear medicine innovations. Please register at prostatecancer-blueearthdx.com for the latest news and pipeline developments.
Hi, everyone. Thank you for watching the PROMISE Registry Study video. My name is Natalie Macario, and I am the Project Associate for the PROMISE Registry Study. We are a virtual germline testing study based in the US and are excited to present here today at 50 Hoops. Registering for PROMISE is quick and simple. You can go to our website, prostatecancerpromise.org, to register online. If you have any questions, please feel free to ask during the Q&A. We are also available Monday through Friday, 9 a.m. to 5 p.m. Eastern Standard Time at 646-449-3363 and via email at pcctcpromise@mskcc.org. Thank you. Thank you. If anyone had any questions, please feel free to add them in the chat. I'm also going to add a couple of Q&A questions that are pretty common. Just kind of describing a little bit more about what is promised, what our goals are, and any questions about eligibility as well.
Okay, I asked Natalie, could we get a copy of the video? And she said,
of course, absolutely.
Natalie, there's a question in the Q&A. So,
yeah, thank you for responding now.
could you read them out loud so the other folks can?
Sure. So one of the questions is, does it cost anything to join Promise? And no, Promise is completely at no cost to you as a participant. So there's no worry in terms of that. Even shipping, the shipping label is also provided, so you wouldn't have to pay for that either. And another question is, why should I join? So there's a couple of reasons why you should join. So it's a great way to learn a little bit more about your prostate cancer treatments or your diagnosis. And it's a great way to have more of a communication with your doctor in terms of what might be the best options for you in the future and also for your family. It's a great way to understand your family history and its genetics as well.
I see another question in the chat. It says, with many Black men not trusting research, can you tell us what happens to the DNA that men submit to the registry?
Yeah, that's a wonderful question. So for us, we do not use the DNA information either outside of research purposes. So there wouldn't be, any implications of using the genetic information outside of just understanding more about what prostate cancer has affected for a lot of these patients. So if you do have a couple more questions, we do have a genetic testing partner. Their name is Color, and they definitely have information regarding what where the genetic information will go, how it's being used. But overall, our purpose is strictly to utilize it for prostate cancer research.
Okay, and the second part of this person's question is, how does the Promise Registry communicate what is being done with the DNA?
Yeah, that's a great question. So one area that we do need to get more information is we need to have medical records from the providers of patients. So a great way to, we communicate our information is letting you know that we do use that information in order to do our analysis. But besides that, we do provide newsletters, we do provide more information throughout the year. We have webinars discussing different prostate cancer treatments, any news that might be coming up in terms of prostate cancer. But overall, the only way we would necessarily have your information is through the medical records of your provider.
So you must have established trust in the areas that you work in. How have you done that? And also, are you collaborating with the medical centers directly, or the patients have to give you that information?
These are great questions. So this is a completely decentralized or virtual study. So you don't necessarily need to go through your doctor in order to sign up. Although, of course, we do recommend it. You can completely just go online on the website, which is prostatecancerpromise.org, and you'll be able to sign up just with the click of a button. And once you click that Join Us button, you'll be able to go to our genetic testing partner, Color, which I mentioned before. And they will just ask you a couple eligibility questions, and they'll just, have a sign up area where you'll have a username, a password, and you will get your your kit shipped to your home or your shipping address. So it's pretty simple. You don't necessarily need to have a relationship with your doctor directly in order to sign up. But like I said, we do encourage you to share your results. And results come in between 4 to 6 weeks, and you get the opportunity to talk to a genetic counselor and be able to learn more about what your results may be.
Awesome. Thank you so much. Any other questions?
I hope I answered all the questions. If I missed any, please let me know.
Let me check the chat one more time.
There was one more question in the Q&A. I don't know if you saw it. Who are the doctors behind?
Okay, who are the hospitals and doctors behind Promise? Yes, so I think I missed this question, so thank you for reminding me. So we do have a number of providers and hospitals. So we actually also have two PIs, principal investigators, which are Dr. Channing Pollard. She comes from Johns Hopkins in Maryland. And then we also have Dr. Heather Chang, and she is based out in Washington at Fred Hutch. Those are the two principal investigators. And of course, we do have a big relationship with a lot of different sites throughout the US. We actually have sites at 49 states so far, and we're actually looking into a lot of different territories as well. So we do have a broad range of hospitals and doctors participating.
One other question, do you partner with HBCUs?
Yeah, actually, we are looking to gain more of a relationship with a lot of HBCUs. So we are looking to have more relationships with Morehouse and Howard, and of course, any of the other institutions that would be interested. So, we would love to have more of a connection with them if anyone, has a way to build that relationship. But overall, we are looking to expand and diversify the study more.
Thank you so much. I believe that was all of our virtual vendors. Am I correct, Terrence?
That is correct.
Okay, so finally, we will select from our virtual audience to provide giveaways. And Ms. Pat and Ed, they always find a way to engage our audience and also to make you feel happy that you attended. So they have some gifts that they would like me to raffle off to you guys. And I have written out some names and put them on a little piece of paper. So I will now, and Terrence, you'll have to let me know if this person is still on the line with us or still virtually present. Okay, the first gift is a $50 gift card, and it goes to Ken. Is Ken still on the line? Ken, congratulations.
Ken is still on. Yeah.
Congratulations, you have won a $50 gift card from 50 Hoops. Please put your email in the chat and also connect with 50 Hoops to receive your gifts. So put your email in the chat so that we can remember that you received the gift card. And I'm writing this down. Okay, next person is Dolores. Is Dolores still on the line?
Dolores is still on as well.
Okay, Dolores, you will receive a 50 Hoops anniversary t-shirt like we're wearing today. Dolores, put your name in the chat and your email.
So some people said the chat is disabled. I'm going to try to put it back online. Okay.
Okay. Or you can put it in the Q&A if that works for you. Okay. We have the next person is Troy. Is Troy still with us?
Troy is still on as well.
Okay. And for an edible arrangement, we have Trish. Is Trish still on the line?
Trish is also still on the line. Yes.
Okay, and we have one more prize. This goes to Kelly. Is Kelly still on the line? Or still with us?
Kelly is on as well.
Okay, Kelly, you will receive a 50 Hoops anniversary t-shirt. And that is all of our prizes for today. Now we'll have our benediction. Following those who wish to stay on the line, you can enjoy the rest of the basketball tournament. So I'll turn it over to Miss Pat and 50 Hoops. If there are no other questions for our speakers or our vendors, are there any other questions for our speakers or vendors before we transition? Okay, I'll give you some more time to put your information in the chat or the Q&A.
I did want to mention one thing that was very important, the importance of genetic testing. This is extremely important, as I mentioned before, because the new drugs and therapies are going to be based upon your genetic makeup. And I think that any person either has a family member or has prostate cancer, a history of prostate cancer, should really take advantage of the Promise Registry. And as Natalie stated, it's important, it's free, and it's not a requirement for you to get approval by your insurance company. And the reason why I bring this up, and I think a lot of people don't understand, that if we look at statistics in Dallas County, just in Dallas County, from these are National Comprehensive Cancer, or NCI statistics, or CDC statistics, that in Dallas County, there was 1,100 new prostate cancer cases. So, and that was real-time data from 2020. So it's important. And as I mentioned before, these new cutting edge therapies are going to require a better understanding of your genetic makeup. So it would be very important for them to take advantage of the Promise Registry program, especially if it's free, especially if you have prostate cancer. So I just wanted to highlight that.
Thank you.
I'm not certain if Miss Pat is available and if she wants to say some words before benediction, but if so.
I saw a note from Trish, and Trish wants to donate her gift back. Is Ann still with us? Terrence, is Ann still with us?
Oh yeah, Ann is still with us.
Okay, Ann, please put your email in the chat or the Q&A. The Q&A might work. Okay, I don't see the emails in the Q&A. I will give these names over to 50 Hoops, to Pat. Thank you all for your time and participation today. Thanks to our speakers as well as our vendors and sponsors. I'll turn it back over to Pat for our benediction. Pat, are you ready?
So we can go ahead and do the benediction, and then for the remainder of the program, you guys will be able to see the game. So I'll go ahead and start the benediction.
Let's prepare for the benediction. Lord, as we prepare to dismiss from this place and by live stream, we pray, Lord, that your strength will sustain us, your power will preserve us. We pray, Lord, that your hand will protect us, And we pray that your peace and your love will go with us this day and every day. And you will continue to bless us and our families. In Jesus' name, amen.